Good morning, everyone. We'll go ahead and get started. My name is Juliet Martinez. I'm Vice President of Community Impact with the American Heart Association, and I wanted to welcome you to the autumn webinar for Healthy Hearts California. Also joining me is my co-host, Tiffany Richards from the Department of Health. Tiffany, did you want to come up and introduce yourself really quickly?
I can. I'll say hello again at announcements. Good morning, all. My name is Tiffany Richards, and I lead the cardiovascular disease prevention program here at the state. And part of that work is leading the Healthy Hearts California network. So thank you all for being here today.
Thank you, everyone. And so really during our time together today, we're going to dive a little bit more into heart failure. So we're going to review the agenda. If we could go to the next slide, of how we'll spend our time together today. So one thing before we go through the agenda, if we just wanted to quickly review the vision, Tiffany, for the Healthy Hearts California framework, would be really to have healthy hearts for all Californians. And the mission is to reduce the risk and prevalence of heart disease and stroke among all Americans. So really, as a collaborative working together to make sure that California and beyond is heart healthy and for ourselves, our communities, and for our healthcare professionals. Next slide. And so, looking through our agenda together, we're going to be having a focal time around heart failure today. And as part of that, we'll be having a discussion, but with heart failure, and that will include, I will be moderating the panel along with Dr. Richard Rothschild, who's a cardiologist from St. John Regional Medical Center. He will be one of the panelists, as well as Dr. Steve Chen, who's the Associate Dean of Clinical Affairs at the USC School of Pharmacy, and Wendy Masuka, who is a cardiac electrophysiology nurse practitioner at St. John's Hospital. We will also have time for a question and answer session. So if you do have questions for the panel, please feel free to write them in the chat as we go through the conversation. We will also have a policy update from Jamie Morgan, who is the Government Relations Regional Lead for the American Heart Association. And then we'll turn it over to Tiffany and everybody on the call to talk about announcements and stakeholder sharing. And then we'll adjourn the meeting. So just wanted to see if before we go through the agenda, are there any other issues that we would like to make sure that we cover? I know Hattie, you had asked for the OPA performance data. So at the end, during the announcements and stakeholder meeting, we will give the screen share to you if that works. If you could just confirm that and if that does work for you. Okay, we are waiting for one of our, so as we go through the objectives today, we're going to be looking at the link between high blood pressure and heart failure. We're identifying the common risk factors of heart failure and learning best practices in addressing heart failure. And then we're receiving and sharing information, including prevention-based strategies among partners. So now what I'd like to do is I'd like to welcome Dr. Richard Rothschild to do a quick level setting with us on heart failure. Dr. Rothschild, I'll turn it over to you. And Dr. Rothschild, can you I don't think we can hear you. We see your screen, but we can't hear you. Is it just me?
No, I don't hear anything from him.
No audio yet.
Dr. Rothschild, you may have to join audio, please. Okay, so what we'll do right now is we'll pivot. So if you could go ahead, Dr. Rothschild, while you get situated. Jamie, if you'd be okay, we'd like to just jump forward to the legislative updates while Dr. Rothschild works on the audio issue?
Sure, I'm happy to.
Let me pull up those slides for you, Jamie. Give me one
Please,
second.
thank you.
Okay. Okay, well, good morning, everyone. I'm Jamie Morgan. I am the Senior Region Lead of Government Affairs for the American Heart Association. I am based here in California. I cover our state policy here as well as in Alaska. So two very different legislatures, but there are some similarities. If you can go to the next slide, please. I'm going to give a brief legislative update. There are a number of bills that we could talk about. I think a record number of bills were introduced this year, over 3,000 if I'm correct. So I'm not going to go through all of this, but I will touch on a few, and just to kind of back up and let you know kind of where things stand right now with the legislature. They have, in September, they adjourned. So we just finished the first year of a 2-year legislative session. They will come back in January and have an additional year to pass legislation. So some bills did not make it. Some bills are now 2-year bills, but you will see that most of the bills that I will be talking about today, action has been taken on, but there are certainly a number of health-related bills that are still in play, if you will. Excuse me. And just a little bit about the legislature. We saw quite a few new faces this year. There are many, new elected officials, and there have also been some leadership changes. Specifically, Assembly Member Rivas is now the Speaker of the Assembly. We can expect some committee changes probably in the new year. He hasn't released what those changes will be yet, but there could be new chairs of key committees that we are where our bills go. And in the Senate, Senator McGuire will become the pro tem, but that will probably be later in the spring. And then in terms of priorities for leadership, and I think this includes the governor, we see, housing, climate change, the opioid crisis, and labor rights, among others, as being top priorities. I think with numbers starting to come out regarding the budget deficit, that is going to, kind of frame everything that is considered next year. So if we can go to the next slide. Thank you. Great. So a few of the bills that I'm going to highlight, that I want to highlight, are AB 716 by Assembly Member Warner. This relates to surprise ambulance billing. And, while existing state and federal law prohibits ground ambulance surprise billing for patients with Medi-Cal and Medicare coverage, state law allows ambulance providers to surprise bill consumers with commercial coverage. So this bill limits the amount of health plan enrollee who receives services from a ground ambulance provider has to pay for those services, and prohibits the ambulance provider from billing more than a specific amount. And then, excuse me, and requires the health plan or insured directly reimburse the ambulance provider according to established or approved amounts. This bill was sponsored by Health Access California and was signed into law. Second bill that I'd like to highlight is AB 948, and this bill was also sponsored by Health Access California, and the author was Assemblyman Berman. And you may be familiar with the policy that Californians have been protected from rising prescription drug costs with a $250 copay cap for their medication. That's been since 2017, but that protection is set to expire next year. So this bill makes that copay cap permanent, which is excellent. And the bill also prohibits a copayment or percentage coinsurance from exceeding 50% of the cost to the plan or insurer, and requires, if there is a generic equivalent to a brand name drug, a plan or insurer to ensure the enrollee is insured or insured is subject to the lowest cost sharing that would be applied. And that bill was also signed by the governor. So now AB 1473, and this relates to CPR in schools. This has been a priority of the American Heart Association. It continues to be a priority. A number of years ago, we passed legislation to require CPR to be taught in schools prior to graduation. The bill was amended to require CPR to be taught if those in those high schools that require health classes. So not every high school requires a health course prior to graduation. So what this bill sought to do was to expand it to reach every school. And by doing this, they required it to be in a health class or PE class. Unfortunately, the bill was significantly amended by the Education Committee to require the Instructional Quality Commission to consider increasing the content related to CPR instruction when the health and PE framework is next revised. And that's after January 1, 2024. So not a specific date, not an ideal bill at that point. And as a result of the potential cost impact, the bill is held in the Appropriations Committee. This issue is one we will reconsider next year, but just to kind of give you an overview of what challenges will lie ahead as we pursue this issue. SB 694 was a bill that the American Heart Association co-sponsored along with the California Chronic Care Coalition. The bill would have required the Department of Healthcare Services to adopt two Medicare codes that would allow doctors or providers to seek reimbursement for clinical services as it relates to self-measured blood pressure monitoring. Current law covers the blood pressure cuffs, but does not cover the services that providers provide when they are seeking to have their patients go home and do some self-monitoring. The bill received bipartisan support. There was no opposition. It made it to the governor's desk, and unfortunately, he vetoed the bill. He left a little window of opportunity, and that was to say that, this should be considered within the context of the budget because funding will be needed. So we will be looking at this issue again next year and seeing how we can move it forward. Next slide, please. Great. SB 348 was, thanks, Patty. Sugar tax. Sorry, got distracted there. SB 348, this was a huge win for us. This improves the nutrition standards in school meals. You may recall that universal school meals passed a couple of years ago, so all students receive a free meal in schools. This bill layers on top of that to ensure those meals kids are getting are healthy, and specifically limits the amount of added sugar and reduces the amount of sodium that can be in school meals. The other important piece that I'd like to highlight of this bill is that it requires schools to provide students with adequate time to eat And that will be determined with the California Department of Education. But, we know that if a child is eating lunch and has, the opportunity to go play, may eat lunch quickly, may not eat lunch at all because they want to get out, not be on the playground. So by providing students more time to eat, they will hopefully choose healthier options, which some research has shown. So this is just a way to, ensure that kids have access to healthy meals and enough time to eat. Next slide, please. Sorry for the background noise here. So here are some tobacco control bills that we act this year. The first bill is AB 374 by Assemblyman Haney. And we've seen a number of these bills the past couple years, and they relate to cannabis and specifically trying to expand the business model. This bill would have allowed for the preparation and sale and consumption of non-cannabis food and beverage products. So this would have been allowed in on-site consumption lounges that are approved at the local level. So it could include, edibles, but also smoking cannabis. And that would be, for over 20 years, we've had smoke-free restaurants. So this would kind of, move us back, allowing virtually restaurants to be in these on-site consumption lounges. So it's something we very much opposed because of the exposure of secondhand smoke to potentially a whole new class of workers. And fortunately, the governor heard us and vetoed the bill. AB 935 by Assemblyman Connolly related to the flavored tobacco ban. I'm sure you're all very familiar with this bill regarding flavored tobacco. We passed the ban a number of years ago. The tobacco industry sued, and then they put a measure on the ballot to repeal the law. And we were successful in fighting that back. So this bill builds upon the flavored tobacco ban by providing DPH, the Department of Public Health, and others more clearer guidance on how they can enforce the law. And then finally, SB 626 by Senator Rubio closed the loophole in current law regarding smoking in hotel and motel rooms. Under current law, you can smoke in 20% of hotel or motel rooms, with 80% required to be smoke-free. Now we have 100% smoke-free motel and hotel rooms in California. So I don't know if I have time to answer questions, but I'm happy to answer questions now or offline later.
If you have questions for Jamie, please feel free to type them in the Q&A or in the chat. Okay, Jamie, I see no questions. Thank you so much for the informative information, and really, I think everybody here on this call will be really vested in all of the issues, but I think in particular, right, SB 694, when we come back to revisit that on the self-measured blood pressure, that a lot of us will want to come together and see how we could support that. So we do get it signed next year.
Yes, thank you. I will certainly keep you updated on how we're going to achieve success next year, because we will need help from everyone. And we definitely want to see this bill get over the finish line.
Thank you, Jamie, so much. And again, if anybody has questions, feel free to type them in the chat or in the Q&A, and we'll also provide Jamie's information if you would like to contact her directly.
Thank you.
Thank you, Jamie. Thanks. And so we will now move to the next portion of our program, which be, I believe Dr. Rothschild was able to connect again. So we'll go ahead and ask Dr. Rothschild if he would be willing to share his screen, and he can do level setting on heart failure with us. Dr. Rothschild?
Can you hear us now?
We can, yes, thank you.
Oh, wonderful. Thank you, thank you. I apologize. Computers don't like me very much. You know, I was going to add very quickly in terms of the bills at the state level. You may or may not know, but Medicare now has a similar process, and we're getting blood pressure monitors and weight scales for people to follow their weights at home for Medicare recipients. And it just started recently, but my impression is that it has been helpful for at least that population. So just a little plug for that as well. I was asked to talk real quickly about heart failure. I think you probably know about this, but I will go very quickly, or as quickly as I can. Obviously, heart failure is a broad topic. So as you said, we're going to go around the heart in 60 minutes, hopefully less, and you can see kind of outline of what I'm going to try and do. And oh my, okay. So the scope of the problem is, I mean, you know this, heart disease and heart failure is the #1 cause of death in the world. Financially, hundreds of billions of dollars are spent annually. That's probably an underestimation. More importantly, the personal life and countless lives lost, adversely impacted lifestyles and quality of life. It's the #1 cause of hospital admissions as well as readmissions. So you know all this. It's a horrendous problem. What do I do now? The best question I was ever asked, this is from one of my classes in school, is the heart where God is? We'll get back to that, but about a little bit of philosophy and all. Some fun facts, there's a lot of dry things here. Just for you just to know, you kind of might know if you have a dull day and you want to kind of impress someone, your heart beats 100,000 times a day, 35 million plus a year, unless it's a leap year, then it's a little more, 2.7 trillion times a lifetime. If you lined up all your arteries, veins, arterioles, capillaries, end to end, you'd go around the world 2.5 times, about 50,000 miles. One drop of blood is, 250 million red cells, 17.5 trillion red cells in your body. If you think about everything that has to go right, it is really a pretty amazing organ. But what it really does is it pumps blood around your body. So in addition to being the repository of love and soul, as you see, it circulates blood around the body. And there are 4 aspects of the heart. You know this. The first is the pump, how strong your heart muscle squeezes. Normal ejection fraction is how we measure heart strength, is around 60 to 65%. Heart failure is divided into low ejection heart failure, which is less than 40%, and preserved ejection, which is over 50%, still not quite normal. The heart also has 4 valves. The valves are there like in any pump so that the blood moves forwards and not backwards, like a valve in any pump. Your heart has an electrical system that it controls your heart rate, but it also maintains the proper coordination for your heart to contract. You don't want one wall squeezing first and the other wall pushing the other wall away, then the first wall squeezing, pushing the first wall away. So you need it to contract together. And then finally, it's what I call the plumbing or the coronary arteries that actually brings the blood to your heart muscle so your heart can work properly. The heart is a muscle, and just like the muscles in your arms, your legs, it needs blood to work. Blood obviously has oxygen nutrition that your arm muscle needs to work and your heart muscle needs to pump. So you can have a problem with any one of these 4 aspects of the heart or combinations of thereof, and that will then lead to the heart functioning poorly, and that leads to heart failure, whereby your heart cannot do what it's supposed to do and pump the blood around your body. In addition, if there is a problem with one of these 4 areas, it can often affect the other areas as well. So, if you have a problem with your electrical system, that can affect the pump. If you have a problem with the valves, that can affect the pump as well. So these things all kind of interact. And again, when the heart does not pump the blood adequately, that's what leads to heart failure. The blood's backing up and the heart's failing. We'll talk about the specific things in a moment. But importantly, if you recognize a problem, we have really very robust things to help us out. So we want to go over that real quickly. And so thereby you need to know the signs of heart disease so we can seek appropriate help. You know this, the circulation, blood goes from the veins into the right atrium across the tricuspid valve, right ventricle across the pulmonic valve to the lungs where it gets oxygen and gets rid of CO2, comes back to the left atrium across the mitral valve, left ventricle, and out the aortic valve here to your aorta. The aorta then goes all the way around and back again to the beginning. You don't see the plumbing of the coronary arteries. In profile, we'll show you some other pictures here. It's the plumbing. The electrical system is not well seen, but you actually do have electrical fibers that are there that help the heart rate as well as the contractility, so the left ventricle squeezes in synchronously together. And you can have problems with any one of these aspects that can then lead to heart failure or combinations thereof. So heart failure is classified different ways. There's a left heart failure and a right heart failure. Left heart failure just means the left side of the heart is failing, meaning the left ventricle. And that can be then, so your causes, or rather your symptoms when you have left heart failure is the blood will back up from the left heart into lungs. So you get short of breath or dyspnea. You often get orthopnea or nocturnal dyspnea, which is shortness of breath when you lie flat or waking up short of breath. You can often have exertional fatigue. Often cough and wheezing is a sign of left heart failure as well. Now, obviously, other things can cause this also, but this can be a sign of left heart failure. Renal failure, the heart bone is connected to the kidney bone. And so when the heart's not pumping blood well, you get renal failure. All of these things are manifestations of left heart failure when there's a problem with the left side of the heart. Then there's right heart failure. That's obviously a problem on the right side of the heart. And that's usually manifests when the blood backs up from the right side of the heart. So you have peripheral edema, you'll have increase in weight, you'll have abdominal distension, you have early satiety, which is often from the hepatic engorgement when the blood is backing up. And this is one way of classifying heart failure. There are other classifications as well. The systolic heart failure means that your left ventricle is not pumping well and is weak. Again, we mentioned earlier that means ejection fraction is less than 40%. They have an intermediate category as mildly reduced heart failure, which is 40 to 50%. And then the preserved or diastolic heart failure or preserved ejection fraction is over 50%. For a heart to work well, it has to squeeze well, obviously, but it also has to relax well. If your heart doesn't relax well, then it can't pump well blood either, and so you can get this diastolic heart failure, or you might have problems with your valves. The heart could be nice and strong, but the valve is regurgitant or leaky, so when the heart squeezes, blood goes backwards, and again, you have heart failure. And then you can also define heart failure as being acute or chronic, or it can be acute on top of chronic, and so you can get combinations. People present with acute on chronic heart failure, with diastolic heart failure, combined systolic diastolic heart failure. But this is the way we try and classify heart failure. And I don't know what happened. Okay. All right. So systolic heart failure, very quickly, it can be ischemic. That's the most common. That's when you have problems in the coronary arteries or the plumbing. It can be related to electrical problems where your heart's always beating fast, and that can make your heart muscle weak. It can be other problems with the electrical system, what we call bundle branch blocks, or pacemaker related, or lots of skip beats can cause the heart muscle to become weak. You can have toxic and metabolic problems, as you see here, sepsis, thyroid disease, and the like. Valvular problems can make the heart muscle weak. Viral cardiomyopathies, high blood pressure, mentioned earlier, can cause this. The heart muscle to become weak, and it can also aggravate heart failure, obviously. And then the idiopathic heart failures, we don't know what's causing it, so we get a name, call it idiopathic, and it sounds like that we know what we're talking about, but it means we don't know why it's there. Diastolic heart failure, again, is preserved ejection fractions. Ejection fractions over 50%. That has to do with diastolic compliance, so the heart's not relaxing. Usually that's from left ventricular hypertrophy, often seen with high blood pressure, but you can have infiltrative processes as well. Pericardial disease can do this. Other causes of diastolic heart failure means that the heart is squeezing well, but it's not working because of valvular problems. The valves are blocked, aortic stenosis, regurgitation, mitral disease. Fluid overload, you can have a nice strong heart, but if you have fluid overload, you'll go into heart failure as well. That can happen from kidney troubles, urinary retention, salt indiscretion. And then the right heart failure, cor pulmonale, pulmonary emboli, all sorts of things that can cause right heart failure. High output heart failures, again, the heart's nice and strong, but you can go into failure with severe anemia, an overactive thyroid, shunts. Sometimes we get that with hemodialysis fistulas and intracardiac shunts like atrial and septal defects and ventricular septal defects. There are some imposters where people look like they have fluid overload from venous insufficiency and lymphedema, low albumins, and nephrotic syndrome, and kidney problems that can lead to fluid overload and heart failure as well. So it gets to be pretty complicated, and we're trying to review this very quickly, but mostly divided into preserved and ejection fraction or non-preserved. This is the plumbing, as I was calling, the coronary arteries that come off of the aorta, the first two branches off the aorta, and literally backtrack back to the heart. When you have blockage of these arteries, that will then affect the heart function, both systolic and diastolic. When the artery is blocked off, you can then have a heart attack and your heart muscle becomes damaged. This is actually an intravascular ultrasound picture I thought you might like of someone with an unstable plaque. I hope you can see my cursor, but this is where your lumen is, that blood is flowing. This circle is our intravascular ultrasound catheter. This is the, over here is where your plaque is, and this was the covering of the plaque, which ulcerated or cracked or fissured. You can see the diagram over here with the menu. And so this was a person who had an atherosclerotic plaque, it cracked or fissured, and that then exposed the blood here, which has platelets and clotting factors to the medial or middle part of the artery wall. A clot forms very quickly and you get unstable angina. This again has to do with the plumbing of the heart that leads to heart attacks and heart damage. This is an autopsy specimen, the same thing. The lumen is down here. The plaque was up here. This was the thin wall covering the plaque with ulceration and crack. Obviously, this patient didn't do so well with the autopsy slide. Nowadays, if you get in quickly, you can do these angiograms. We do this through an IV in the wrist, the radial artery, or sometimes through the femoral artery. We have a catheter here. We're injecting dye, which is white in here, going down the artery. And you can see right here where the artery becomes very narrow because of this atherosclerotic plaque with clot on top of it. It's quite narrow. This is just a blow-up and enlargement. And nowadays, through these IVs, we can put little stents, and we can then open up the artery. The stent stays behind like an internal scaffold to keep the artery open. And now blood can go down to the artery, and it's been a great advance in terms of treating the coronary artery disease that leads to heart failure. Risk factors for coronary disease, you know this, modifiable risk factors, hypertension, diabetes, dyslipidemia, smoking and drug abuse, obesity, sedentary lifestyles. These can all be changed. The non-modifiable, men tend to get this more than women until after menopause, when women start to catch up. Your family history, you can't change, I'm sorry. And unfortunately, your age, you can't change too much, although I've been trying. I have some jokes here, but we're going fast, so I won't do that here. Symptoms of heart disease, people talk about chest pain. They talk about the elephant standing on the chest, but it's not really a pain so much. It's usually pressure, tight, ache, squeezing, oppressive feelings. It doesn't have to be the chest. It can be in the neck, arm, jaw, between the scapula and the back. Usually comes on with exertion and better with rest and nitro under your tongue. It can sometimes be associated with shortness of breath or nausea, cold sweat, or diaphoresis. People have cold sweats, don't walk away from them. It's a bad sign. Regular angina, usually a few minutes to 15 minutes. Longer durations may mean a heart attack. If it's a second or two, it's probably not your heart. Often you get short of breath, as I said earlier, especially with exertion or when lying down. You get the swelling, that's the right heart failure. You may get an increase in weight, that's from retention of fluid. I tell my heart failure patients, they weigh themselves every morning. If the weight goes up 2 pounds overnight or 3 pounds in a week, they're retaining water. That's probably your first sign of impending heart failure before they notice the swelling in their legs and shortness of breath. They might have arrhythmias, they can feel lightheaded, they can get exertional fatigue, coughing, wheezing. It can be very hard. And it doesn't always involve chest pain, as I said. Sometimes it's just exertional fatigue. It doesn't have to be your heart, but that may be your only manifestation. So it can be a little bit difficult. The presentation we kind of talked about already here. We do have all sorts of tests to look for this as well. Some misconceptions that I think people should know about really quickly. A lot of times I'll have patients say or think if the pain is mild, it's not serious. Unfortunately, when it comes to the body and the heart in particular, that's not true. I have lots of patients that, doc, it's no big deal. I can deal with it. They may be having a massive heart attack that can even kill them. And then the converse, if the pain is really bad, it must be really bad and dangerous. That's also not true. The severity of the pain doesn't really tell you how serious the problem is. Sometimes my patients say, my blood pressure or cholesterol is finally normal with medication, so now you can stop the medicines. Unfortunately, that's not true. This is not like a strep throat where you kill the streptococcus bacteria and now you don't need the antibiotic anymore. This is a condition that needs to be maintained. Sometimes if people lose weight, if they exercise well, change their diet, they can get off medication. But it's not just so simple. I took the medicine, it's now my blood pressure is normal, I can stop. Sometimes they'll say that heart test is normal, they don't have any blockages, and no, that's not true either. The test won't pick up all blockages, and it may be that on medicine things are controlled. They still need to take good care of themselves. They eat right, exercise, they don't have to worry. Unfortunately, eating and exercise are only affect some of the modifiable risk factors. There are non-modifiable risk factors that are not affected by this, obviously. Others say they had their bypass surgery, angioplasty, they don't have to worry. Unfortunately, whatever it is that caused the bypass to be done in the first place is still there, so they still need to take care of themselves. Not all chest pain is a heart problem, so it can be confusing. And sometimes if you don't have chest pain, you can be having heart disease. As I said, sometimes it's shortness of breath or fatigue. So it does become a little bit difficult, but these are the things that we all grapple with. It's fooled many good docs and many good patients for that matter. Your evaluation always starts with a history exam, and then we have all sorts of tests that can be used, the treadmills and stress echoes and scans and such, which are very, very helpful. There have been a lot of new advances. The coronary calcium scores are now lower radiation and such, CT angiograms, glucocorticoids to look for heart rhythms. Some of the home monitors are very good, can be used as well. To be frank, my mother sends me a rhythm twice a day with her home monitor. So there's been lots of evaluation advances very quickly here. Advances in treating pump problems when the heart muscle is weak, they've been huge advances lately, and these are some of the things just very quickly. It's a little bit beyond the scope of my talk here, But these are the things that when we get to it, means we failed our job. You really want to somehow preserve the heart muscle first. So there are things, once people have had problems with huge advances, especially medications, you'll hear more about that. But when you get here, we failed. We want to prevent this from happening. Valve problems can affect the heart muscle. We evaluate those with ultrasounds and treatments with valve replacement surgery, but now we can do valve repair surgery. And more recently, we're doing percutaneously. We're fixing our valves with the TAVRs, the transcutaneous aortic valve replacements, and mitral clips and tricuspid clips. And it's really amazing. So a lot of these valve problems that lead to heart failure because they affect the heart function can now be addressed percutaneously, and there have been huge advances in surgeries as well. This is a quick picture, a diagram I thought you might like of a TAVR. The valve here is the aortic valve with your left ventricle. It's not opening well, so we put a wire across the valve. We can put a balloon over the wire and inflate the here to kind of stretch out the leaflets a little. Then we put in what's called a TAVR. And what this is, it's a little stainless steel wire mesh. And inside that are leaflets that are moving, and it's all mounted on a balloon. We inflate the balloon to expand that stainless steel wire mesh. Then we take the balloon out. The stainless steel wire mesh, kind of like a big stent, stays behind. And inside that are these valve leaflets that can move normally. And we're getting bigger valves, literally through an IV in the groin. This is the catheter that does this. Often they don't even have to intubate the patients. It's done under conscious sedation. Often they can go home the same day or the following day. And we're getting bigger valves than we get with surgery. It's just amazing what the technology has done. Electrical problems, the huge advances. We have regular ventricular pacemakers, atrial and ventricular pacemakers. We have smart pacemakers that are rate responsive. The heart rate can go up when you exercise and slower backup rates when you're at rest. We have even smarter pacemakers that can pace the heart to get it to squeeze in together with better synchrony or coordination. We have leadless pacemakers that are just put in the heart that don't have leads. We have shocking pacemakers, kind of like your own personal paramedics that can shock the heart if you have arrhythmias. We have new treatments for atrial fibrillation, of ablations, and Watchman devices to decrease clots. All of these electrical problems can lead to heart failure and affect the heart muscle function that we can now address. This is just a picture of a biventricular pacemaker. The pacemaker goes under the skin here, just kind of below the collarbone. And from this pacemaker device, we have these leads that go into the subclavian veins that then go down to the heart. There's one lead here that's right here in the right atrium. We have one in the right ventricle, and then one goes to the coronary sinus to the other side of the left ventricle. And so when these two leads fire together, it will then can affect the synchrony with which the main walls of the left ventricle squeeze, so we get better coordination. But this is how our biventricular pacemakers will work. This lead is also able to shock the heart if the patient has a ventricular tachycardia or ventricular fibrillation. Can overdrive pace the heart to take care of arrhythmias. It's pretty amazing what we can do. Plumbing problems we talked about earlier. We have our clot busters and balloon angioplasties and stents and drug-coated stents and roto-rooters and ultrasound to take pictures and measure pressures. We have can go through the radial artery now. Don't have to go through the femoral. We have new methodologies of heart surgery. We don't have to stop the heart, and we have beating heart bypasses. We have cardioplegia to protect the heart when we're doing surgery. We have robotic-assisted surgeries. All sorts of things are just amazing now. We have, I didn't add here, shockwave balloons, kind of like lithotripsy, where we can take care of plaques that way. So there's all sorts of things that are being done to affect the plumbing. This is kind of a quick schematic. If you have a blockage in the artery, we can come in and we put our little balloon that has a stent on it. We inflate the balloon, we take the balloon away, the stent stays behind, and we can open up the artery to get more blood to the heart, let the heart work better. So there's some treatment strategies, and I think here when the Carpenter's adage is measured twice, cut once, and do it right the first time. So when we discharge patients, I think we do an imperfect job, and we need to get the discharge right. And that probably means having someone talk to the patient beforehand that they're on the right medications, the right dose, and most importantly, that the patient can access the medication. I'm embarrassed to say I've sent patients home multiple times, and they say, "Doc, I can't afford the medicine you gave me," or "Doc, it's not on my formulary." And I don't know what the patient's insurance has, to be honest, or what their insurance might cover. But we need to make sure we get this, because it makes no sense for me to discharge somebody on a medication and they can't get it at home, and then we haven't done the patient any good. It does take a village. There's so many people that have to work together for us to get this right. We need to coordinate with family members. Often these patients, 80s, 90s, for them to take 5, 6, 10 pills a day takes, family input and help. They need to check their blood pressures at home. They need to check their weights at home. This is not something that a lot of our patients can do. I remember one of my patients came in with a shoebox of medicines, must have had 20 pill bottles in the shoebox, and she looked at me and said, "Doctor, I don't think I'm doing this right. We need to do this." It involves multiple medical disciplines all working together. They may have kidney troubles, they may have lung troubles, they may have all sorts of other kidney, renal problems that we need to coordinate with. And some of the things that I do may make something else worse in another area. So we often need to coordinate with different disciplines, and not just medical disciplines, but rehab is very important for our patients to get up and about and active. Dietitians and food, physical therapy, pharmacists, really crucial to make sure that what I'm doing isn't adversely affecting another medication that another doctor may be ordering and such, or even over-the-counter medications that may not even be ordered that we're not aware of. So it really does take a village to get this right. And then we need to get organized, and the patient needs to be organized, and I really think, to be honest, we should have all our big places. We should get a 7x4 pill box and put our own logo from our hospital or our company on it, the darn thing, and allow it, so once a week you put the pills out, you make sure they're taking it. And then we have our heart failure clinics, which I think are very important. We're not using these adequately. We need to see our patients within a few days of being discharged. We need to have follow-up. Often this can be done by telemetry, where they're checking their weights and they're checking their blood pressures, because this is something that can affect their quality of life and their overall course and reduce rehospitalizations. Staying healthy, this, eat well, moderate your salt, fat, caffeine, alcohol intake. Doesn't mean you can't have any of it, but you need to do it in moderation. On the top of one of the temples in the Acropolis in Athens, Greece, the Greeks wrote, "Know thyself and everything in moderation." It's not bad advice. They had to be concise. They were chiseling in stone, but I think it's important. Moderation is real important. Exercise, again, in moderation, real important. You don't want your patients working too hard. And a good rule of thumb, they should be able to talk comfortably and complete a sentence while they're doing that activity. If they're getting so breathless they have to stop in mid-sentence, they're working too hard, they should slow down. They need to take their medications appropriately. You'll hear more about medications. There have been huge advances in medicines now. Heart failure patients should be on at least 4 classes of medicines: the beta blockers, the afterload reducing agents, we call ACE inhibitors, ARBs, ARNIs. You'll hear more about that. This new class of medicines, the SGLT2 antagonists, huge new advances. And we now have just very recently combined SGLT1 and 2 antagonists. A lot of really exciting data there. Water pills are diuretics, the mineralocorticoids. And then the other things to help for cholesterols, the new medicines and statins and PCSK9 antagonists, RNA acting things, are blood thinners that they need to be on. And then new class of medicines, also the cyclic GMP modulators. Again, they need to check the weight daily. I tell them empty bladder, empty stomach. So in the morning, after they've urinated, empty bladder, empty stomach before they've eaten, they should weigh themselves. Same way every morning in their pajamas after urinated, before they've eaten. If the weight goes up 2 pounds overnight or 3 pounds in a week, it means they're retaining water. You just can't eat that much food that quickly and gain that much fat that quickly. So that happens, they should take an extra one of their diuretics. And you can actually nip a small problem in bud early before it blossoms into a big problem. Appropriate follow-up, we need to make sure they get this. And again, just never take a single breath for granted, as the song goes. Medications, there are all sorts of new ones here. The heart failure medications we mentioned here. Barostim, you may start hearing more and more about this. This may be a real big new thing that's just coming out. It's kind of like a pacemaker, but it's just under the skin. It doesn't go inside any vessel, and it modulates the autonomic nervous system's interaction with the heart. The autonomic nervous system controls things that happen automatically: blood pressure control, breathing, temperature control, and it's divided into a sympathetic and parasympathetic part. And this is a simple little device that's put in underneath the skin, and it gives off a little electrical jolt that the patient doesn't feel up by the carotid bulb, which has baroreceptors that measure pressure. It fools these receptors into thinking the blood pressure is a little higher than it is. That then sends an impulse up to the brain, and the brain then will lower your sympathetic and raise your parasympathetic tone. And there's some very exciting data on this. You may see more of this. Stem cells, angiogenesis factors are also in their genesis. The few stem cell trials have shown some promise, but I unfortunately haven't seen quite the improvement that I would have hoped for. But that's important because the heart, unlike lots of other things, doesn't repair itself well. And that's the promise of stem cells. That's different from your liver or you cut yourself. They heal rather nicely, but the heart, the brain don't. So that's the promise of stem cells, and this is still a ongoing research, and most of the trials are in their follow-up stages right now. This is a picture of the barostem real quickly if you wanted. I know I've gone fast, so by now it should be crystal clear and your head should be nice and straight and probably spinning a little bit, but I saw these signs. I thought that was kind of nice. It's actually a picture of me and my daughter on the top of Half Dome. She slept me up there, and a picture over the Channel Islands in the back of our yard here. So I'll stop. I tried to go quick, kind of a very fast overview. You obviously know this very much already, but and I'll leave some time for questions and hopefully a couple answers if you have any.
Thank you
boy.
so
I hope.
Thank you so much, Dr. Rothschild, for really, the very informative this overview on heart failure. And so I know there were a couple of questions, but also wanted to know, bring on Dr. Chen as well for the panel discussion that we are going to be building off of your slides as well. So I don't know if you're able to come on camera, Dr. Rothschild and Dr. Chen as well.
I don't know. I have, I don't think I can get on picture,
Okay.
but I'm not a lot, I'm really not much to look at. You're not missing anything.
Okay. So if I could have you unshare your slides, and then Dr. Chen, would you also like to come on as well?
Yeah, I'm muted, video and audio. I hope you can see and hear me.
I can hear you. Yes.
Okay, great.
And Dr. Rothschild will continue to meet with you as well.
Yeah. I'll stay I'll be on audio, but I don't think I can get on video. Sorry.
No, that is okay. So first of all, wanted to see from the audience, are there any questions that you have before we go into the panel discussion? Okay.
Sure.
So, Dr. Chen, one of the questions, that we think about is, as Dr. Rothschild had mentioned, is with heart failure, we know that using a team-based care approach is critical in management. Can you share a little bit from your perspective in the role of pharmacy experts, what role they play and how they can collaborate not only with providers, but also with community organizations and clinicians?
Yeah. Thanks for the easy question. I have to say that Dr. Rothschild, what a great overview that was. This is a conference where the rule of under promise and over deliver really happened here. I thought that was an amazing summary of heart failure. So thank you for that. So I'll frame your question with the whys a little bit, right? And some of the things that I think frustrate me and frustrate many people who are in this line of work. We've been saying for a couple of decades now that the 5-year mortality rate for heart failure is 50%. And yet we do have these amazing drugs that were just highlighted by Dr. Rothschild that have been available for quite a number of years. We're sort of challenged with why are we not able to optimize use of these medications? If you look at utilization, for example, of something something that's been around a long time, the MRAs, for example, spironolactone and eplerenone, there's at least a third, if not more, patients that should be on these drugs that aren't on them, right? ARNIs are still quite slow in getting picked up in terms of utilization. SGLT2 inhibitors, which are amazing, incredible drugs, are being underutilized. So, to your point, I think it does take a village, as Dr. Rothschild said. Pharmacists do have a role. And maybe another reminder of how important this is, there's a statistic that we share all the time. It takes 17 years for guidelines to be implemented. That's pretty shocking, given the fact that with these drugs that we're talking about, we're saying that there's a benefit in health status within weeks. There's a reduction in hospitalizations within a month. There's a reduction in mortality within a month. I mean, these drugs work really well. So kind of gets to the question of how do we make sure these patients get these medications? I'll play off of something Dr. Rothschild said. And his issue was, well, when I prescribe these drugs sometimes, my patients tell me they can't get them. Pharmacists are really good at troubleshooting how to get patients the right drugs, the right options, whether that's, dealing with the Medicare donut hole, finding alternatives, whether that's using patient assistance programs. This is what pharmacists do and troubleshoot all the time. So I think that's a very important role. that pharmacists play in just making sure that patients can get access to these 4 critical drug therapy classes that Dr. Rothschild was referring to. Other things that, again, I think it was so comprehensive what was just shared, but the idea of pre-packing medications, whether they're bubble packs, whether they're pill boxes that are filled on a weekly basis, it'll vary. Pharmacies can do this in the community. If you have a clinical pharmacist embedded with you, I think it's very helpful to have these pill boxes that can be filled weekly, because in some cases, you're going to need to titrate medications. And I've seen some situations where bubble packing, if not coordinated well, can result in patients taking the wrong bubble packet medications at the wrong time, right? So having pill boxes that can be adapted quickly to the changes in medications that are occurring based on symptoms, lab test results, et cetera, I think that's very helpful. I'm, to be honest, in my family, I am not the heart failure expert. My wife has been a heart failure pharmacist for Kaiser Permanente for over 25 years, and she spends all day basically managing and optimizing drug therapy for patients. And if you were to ask her, what's my role as a pharmacist in this space, it is getting patients on these 4 medications. And as she says, probably one of the best ways to get it done is in the hospital, right? A hospitalization stay is 5-7 days, maybe somewhere in that range. If you can get patients on those drugs while they're in the hospital and discharged on those drugs, remember the benefit of these medications occurs within a month. You're a quarter of the way there to getting patients on these 4 medications if you can get it started in the hospital. The other things that pharmacists do in this space deal with drug-drug interactions. These patients, we know, don't only have heart failure. They have multiple comorbidities, diabetes, they have kidney disease, they're taking supplements, they're taking all sorts of different mixes of medications. Pharmacists are trained to figure out what are these drugs doing in terms of interacting with each other, offsetting some of the benefits that are occurring here. That's a big role that she plays. And then titrating and adjusting medications for the other conditions, right? We need to pay attention to everything that's going on here. But in the end of the day, she is getting patients on these critical medications. She's monitoring patients for fluid overload. She's responding by making sure patients adjust their diuretics accordingly. And then something else I'll say is, Lasix is an important drug in heart failure. It's not a life-saving drug. It's not a drug that actually has an impact on long-term outcomes. We really want patients to be on these life-saving medications, the ARNIs, the beta blockers, MRAs, SGLT2s, because if you do that, you can extend life by an average of 6.5 years in your typical 55-year-old heart failure patients, and by about 4.5 years in your typical 65-year-old heart failure patient. That's a lot of years. That's a huge improvement. So sorry, long answer, but that's my my overview.
No, thank you, Dr. Chen. And really, when we think about addressing heart failure and the role of the pharmacy team, right, not only in heart failure, but also some of the root causes that contribute to heart failure, including hypertension, that really, as over the last 10 years, has seen an expanded and needed role, because we know folks often don't get back to their doctors, especially those in under-resourced communities, but they will go see their pharmacist to get their medication. So, thank you, to you and all the fellow pharmacists who really play that critical role in the link of survival.
Yeah, of course, I totally missed your second part of the question. Yes, community pharmacies are widespread in the community. They're within 5 miles of 90% of the population, within 2 miles of 73% of the population. They often have staff that are culturally and linguistically aligned. And there's some data showing that Medicaid recipients are in pharmacies 2 to 3 times a month, right? That's a lot of face time, a lot of opportunity to intercept these patients and help them with their medications.
Thank you, Dr. Chen.
Thank you.
Dr. Rothschild, are you able to share how you've been able to use how you've been able to build relationships with pharmacy teams in helping meet heart failure patients where they are to get the medicines, as you have mentioned earlier, access to affordable medicines, but also to make sure that the patient is getting ongoing treatment, whether through your provider team, or through pharmacy and through nursing and community education?
Yeah, it's a good question. Most of my inter-pharmacy relationship is with the pharmacists here at the hospital, and they've been incredibly helpful, both educationally, but also in terms of trying to make sure our patients get the right medications. Patients get discharged at 8 at night. The pharmacies are closed. They need the medicines. It's a weekend. We need to have a better system here. I do interact with the community pharmacists a little bit, but not as much, and that's mostly the frustrations of refilling medications and things like that, which need to be done. I actually think we should have, I tried to set up what I called a heart failure clinic with a educational component. And this is crucial. And there were like 6 lectures. When they finished all 6 lectures, they got a diploma. They graduated from the Heart Failure University. And one of the lectures was with a pharmacist and explaining the medications, how they need to take them. Is it with medications, without medications? I mean, there's so many things that need to be done in order to make sure we do these things right, the interactions that happen. And here the pharmacists are a wonderful resource. Most of mine are with the in-hospital pharmacists, but a little bit in community as well.
Thank you, Dr. Rothschild, for sharing that. And we talked a little bit about managing heart failure, but what are some of the tools that you share with patients, whether through pharmacology or through, lifestyle interventions? That could you both share some on the preventative side and what some of those root causes are? Like, I know we talked a little bit about hypertension, but other chronic diseases that may lead into heart failure and what we can do to prevent them. And so, Dr. Chen, I'll start with you.
Yeah. So Dr. Rothschild gave a nice summary of the risk factors for heart failure. And in the other day, we love Dr. Rothschild. We want to try to keep patients from having to see him and get the interventions that he described at the end there. So, for example, what we've been doing is we've been trying to figure out how do we help patients with diabetes, with hypertension, with dyslipidemia, how do we help them get full control and optimization of their treatments to slow progression of their condition and get them on evidence-based therapies. This happens in closed health systems like Kaiser Permanente, the VA, where you have clinicians, pharmacists that are embedded in outpatient settings that are doing this work, but it doesn't happen as much, right, for other health systems, other health plans. So we've launched something called the California Right Meds Collaborative. It's a partnership between health plans, community pharmacies, federally qualified health centers, and other clinics. And the idea here is that the health plans help to identify patients with persistently uncontrolled chronic diseases that can lead to increased risk of heart failure, heart disease, et cetera. These patients are sent to pharmacies that we help identify and help train to be very effective at optimizing medication therapies. And then these partnerships with the clinics and FQHCs help to foster communication. I think the piece that Dr. Rothschild was mentioning, which is better communication, better linkage, so that the providers understand what they can get from the pharmacies in terms of services, and they also understand that the pharmacists are not just to track adherence, but also to help adjust, titrate, monitor medication therapy and get patients to goal. So we found this to be very effective at controlling just about any common chronic disease. We just had an analysis done by the CDC that shows it's a very promising intervention that we'd like to see expanded more broadly.
Thank you, Dr. Chen. Dr. Rothschild would love your feedback as well.
Yeah, I think I'd reinforce and endorse everything Dr. Chen said right there. And in addition, as he said, it really starts with education, and especially the education of the patient, and as well as family members of that patient, so that they need to know the symptoms that they're looking for. They need to know how to monitor themselves. And I can't overemphasize, checking that daily weight is really crucial, but also blood pressures. They need to be, the education of appropriate exercise and appropriate diet. And this is where things like rehab programs, heart failure clinics and cardiac rehab programs can be so important. And I think it also is important with the education to impart a little bit of optimism for our patients, because this is a chronic problem. And, it can be very, very depressing for our patients. And as my dad, who was a psychiatrist, said, when he had his heart problem, the elephant didn't sit on his chest, it sat on his psyche. He got depressed. This is a big issue, and patients give up, but they can go to these rehab areas and they can get stronger, and they can see other patients there that have similar problems. So I think these are all the things of the puzzle that need to be put together. But it all starts, I think, really with education. And one of the problems, to be frank, is it's not reimbursed. I mean, I spend a lot of time with my patients to make sure they know how to weigh themselves and how to take their medications, and they're organized, and the things that they have to watch for and how they have to eat. But none of this is reimbursed, and we're all working to long, crazy hours. And it is one of the problems, but it's what we are. It's not what we do, and it's okay.
Can I echo that? What a great point to emphasize. I had mentioned to you that the big role that pharmacists provide in comprehensive medication management is drug therapy optimization. But you're absolutely correct in that most of the patients that we see with persistently uncontrolled chronic disease, diabetes, hypertension, et cetera, have no idea what their condition is. Have no idea what the consequences are, some basic pathophysiology, why they should care. So we start there. We start with helping them to understand in terms that they will understand, how this will affect their lives in the long term. And to your point, that there are plenty of options, treatments, interventions that can significantly improve the course and prognosis for the condition. So I think that's extremely important.
Thank you both for such great insights. Dr. Rothschild, so a follow-up question would be, we had mentioned some of the barriers around getting access to patients, whether it's through preventative or through managing. What role has telemedicine played in preventing and/or managing heart failure?
Yeah, again, it's a good question. And we are using more and more telemedicine. It obviously started with the COVID-19 pandemic and when we were largely forced to do that. And I think it is important. It does allow patients access to us more easily. It has its limitations. I personally like seeing my patients. I like putting my hands on my hands on their hands or their extremities and feeling, what's their cardiac output and listening to their lungs and such. But it's not essential all the time. And I think if patients are doing well, it is a nice way of extending our availability. And sometimes patients are not driving, they can't get in easily. The son or daughter doesn't have to take off from work to see us. We're running late. Happens too often. They can be at home and doing things and not waiting in our waiting room. So I think that the telemedicine has been a huge advance, and especially to be able to at least see the patient, not just talk on the phone. And although, as I said, I'm not the biggest fan of it, I use it, and I think it's been a huge advance in helping us.
Thank you, Dr. Rothschild. And part of that, meeting community members and patients where they are, is also looking at how do we get the resources locally. So like when we look at, for example, rural parts, I know LA County is more, for example, urban, but when we look at Ventura, Central Valley, parts of Northern California, sometimes we have to rely on other community networks. So Dr. Chen, can you talk a little bit about how we can work with pharmacists and community health workers to supplement telemedicine in helping preventing and managing heart failure in patient populations?
Well, that's a stacked question. Okay, let me try to unravel that a little bit. A great question too. So I'm with Dr. Rothschild in that in our collaborative, for example, we encourage our pharmacies to at least see the patient the first time and whenever they need to have an in-person visit. But patients prefer often to have telehealth visits for the reasons that were just shared by him a minute ago. I can tell you that the work that my wife does for Kaiser has been by phone primarily for the last 25 years. And her location has one of the lowest rates of hospital readmissions for heart failure and one of the highest rates of all four key medications being on board. So it works, but you obviously for some patients and for certain situations, you do need to see them in person, no doubt about that. The CSW question is so important, right? We know that 40% of a patient's health is really based on their health factors, right? Their socioeconomics, so social determinants of health, and so on. Only 20% is what we do, right? So if you ignore, the housing issues, the food insecurity, the social isolation, you're probably not going to be very successful at managing their healthcare. So what we're doing, for example, is you probably know this already. The state has authorized about over $200 million a year for CSW services. Funding for CSW services. We're certifying pharmacy technicians in our program to be community health workers so that they can spend that time to address those social needs, those gaps, and connect patients to useful resources in their community. And the time they spend doing that is funded by a separate bucket from the state, which is extremely helpful for this work. As Dr. Rothschild said, pharmacists, physicians don't have a ton of time to provide all of that education and support that patients ultimately need, utilizing community health workers that are well trained. And in this case, pharmacy technicians who actually have some familiarity with medications. I think that's such a great marriage of skills to help optimize outcomes for patients.
Thank you, Dr. Chen. And one of the things that you mentioned that I will also ask Dr. Rothschild to talk about is when somebody is diagnosed with heart failure, we've often heard that from patients and community members, that's a very scary prognosis. And 20 years ago, when I first started at Heart, you know, a lot of people had heart, you go to the heart transplant list is the automatic assumption. But now it really is being treated as a chronic disease. Can you talk a little bit more about how we can support patients in managing, if they've been diagnosed, their expectations of understanding really that evolution of it being considered a chronic disease?
Yeah, again, these are good questions, and it's not a simple answer, but it is true. As my dad said, he got depressed. It's very common when people have heart failure, and to be frank, the mortality of someone with heart failure is usually worse than most cancers. I mean, in terms of putting it in perspective. So these are things that are very scary, and it's a chronic disease. And so again, I go back, it starts with education, but I think it's just sharing, we have so many things now that we can do that we couldn't do before. That the prognosis is really different, but it does require the monitoring. And to go back to telemedicine, one thing that I think is really good with telemedicine is I can now get blood pressures on a daily basis and weights on a daily basis that are automatically uploaded to my office and followed by, a staff in my office. And that's a huge advance. And as I mentioned earlier, the Medicare is doing that. I'm glad to hear that the state may be doing that as well very soon. I think it's really helped manage these chronic problems that contribute to heart failure and heart disease. And then, how do you get patients to access the resources out there and feel a little bit more optimistic? I think that comes with time as they start feeling better. When they start feeling better and say, yeah, they are able to go and walk to the soccer field and see their grandson or something, that's when they start feeling better. That's when you did the right thing.
Boy, I really love that you mentioned cancer in this context because you're right in that the outcomes associated with heart failure are, kind of worse than that domain. At the same time, this is an interesting observation that my wife made. She said, patients diagnosed with cancer, they're going to jump into chemo and take these very toxic but somewhat promising medications for a certain number of years of extra life. When you have these medications that have been proven to be, in terms of drug discontinuation rates, no different than placebo in terms of tolerance, that will add 6-7 years of life to these patients. So, in that context, there's great hope with these meds. If we can get them on board carefully, as the way you've described, good monitoring, but fairly assertively, the outcomes are very good. They're better than ever before.
Thank you, Dr. Chen. And I would also like to welcome Wendy Mazuka, who has joined Dr. Rothschild. So thank you, Wendy, for being part of our panel. And so, Wendy, I'm going to ask you a question now. We know that one of the things in the conversation that's emerged is readmission rates of heart failure patients. And usually there's a large number of patients that readmit into the ER after 30 days. What are some of the ways that you've been able to, in your role, help patients better communicate with their providers? Because a lot of times, right, it's having that treatment plan and the adherence to the plan. How do you build support for them?
Thank you for having me, and that's a great question as well. One of the first things that I noticed, I'm fairly new in my role as a nurse practitioner here at Dignity Health, and one of the very first things that I noticed in the first couple of months in rounding on patients is the large number of readmission rates. I would have a patient in my book, and I'd say, oh, I've already have this patient in here. I've seen this patient before, just even fairly early on. So one of the things that I really like to hit on with patients, and I pride myself in that I have a little more time to do this, is the education piece. I really try to discuss with them, like kind of figure out what they have, what resources they have, what kind of family support they have, and really try to empower that patient and what they can do for themselves. The pill box is just a simple thing, but if they can do that, sometimes it feels very empowering for them, just to help them figure it out, to discuss with family ways that they can help their loved one in a efficient, effective way. Because a lot of times families want to do that. So just kind of helping them figure it out. One of the biggest things that I also really discuss with patients is the follow-up. Please make sure you're following up. And then I'll kind of go through like, now this is the list of physicians that you have. You have your primary care physician. Because I'm specialty in electrophysiology, I always hit with the patients now, make sure you're seeing your primary cardiologist, but you're also going to now see your, electrocardiologist too, on that list. So I'm just really making sure that it's more clear to them the huge handful of things that they have to do when they get home that can be so overwhelming for the patients. But I always want to make sure they're having their follow-up care and letting them know the time frame that they should be having that follow-up care within.
Thank you, Wendy. And so as a follow-up question to that, you'd mentioned the family and the caregivers. What strategies and tips would you have for somebody who is a caregiver or family member for someone that has heart failure on how to cope for the self-care for themselves, and how can they utilize some of the tips and techniques that you as a nurse practitioner have that others could benefit from that are caregivers?
A lot of times I will just ask them, what do you have? Do you have a blood pressure cuff at home? Do you have a scale at home? Are you weighing yourself? Are you looking, really hitting on signs and symptoms? When you're becoming increasingly short of breath, or when grandma or mom, dad, whomever, all of a sudden now they're having a lot of swelling in their body, but they can't breathe, or when they're laying down at night, they can't breathe. Are you sleeping in a recliner chair? Just asking some simple questions like that, and helping the family identify some of those problem areas. And they can say, oh yeah, well, we can make sure that, we get this daily weight, or make sure that we're checking, blood pressure daily. I've went through, like Dr. Rothschild said, sometimes it's just even little things like, how do you weigh yourself? When do you weigh yourself? When should I be checking my blood pressure? And is it okay to use this specific type of blood pressure cuff versus this one? And so just really helping that family and that support network, as well as the patient, identify some risk factors and what to look for, and how do we act upon those, to try to prevent the rehospitalization. We can manage this at home, or try to manage this at home. And when is the time that I need to call my cardiologist to say, hey, this is what's going on?
Thank you, Wendy. I think that's a lot of great information for us to utilize, because I think, as we see heart failure continue to increase in the United States, I believe that there's 670,000 cases annually, and that's up from 500,000, that we're going to see more caregivers and family members that are going to need to have the support and the tools. So really great insight there. For the panel question the last question would be, what are some of the tools and resources that you would like to share for medical providers or the community about heart failure and addressing and preventing heart failure? So 1 to 2 of your favorite resources. We'll start with you, Dr. Chen.
Sure. I think I'm biased, but my resource that I'd like to offer up is our CalRightMeds Collaborative. Again, it's taking community pharmacists, advancing their training so that they understand how to help optimize medication therapies for common chronic diseases, including heart failure. And this is done through a value-based payment with health plans. So our proposition to providers is there's no cost to the provider. The health plans are paying for the service. A pharmacist in our network are specially trained, and not just once. We train them to death. We have training sessions twice a year in person. We have webinars every single month covering everything from disease management to patient engagement to managing social determinants. So that's one resource that we're trying to get more widespread out there, because it's needed. To everyone's point here, the health system has certain hours. They're not available, on weekends necessarily all the time, or late at night. Pharmacies are. So we're trying to optimize utilization of this underutilized resource in the healthcare system in ways that just make sense. The other is we're starting to get into remote therapeutic monitoring, and I think we've been talking about some of this a little bit, as opposed to RPM, which is much of what we've already discussed with heart failure, the scales and the blood pressure cuffs, etc. RTM are things like devices that track opening pill bottles or utilization of medications, so that we can intercept real time when patients are starting to not take their medications and intervene accordingly. And maybe if I can say something really quickly there, one last point I want to make is patients have this gravity towards not wanting to take medications at some point. And I want to say that very clearly, because as patients improve symptomatically, as their ejection fractions improve, they're going to want to ask that question, or maybe make the assumption that maybe I don't take these medicines anymore. And I think in heart failure, that is tremendously not what we want them to do. They need to be on these medications for life. We know that if they stop taking these medications, they'll decompensate within 6 months or less.
Thank you, Dr. Chin, and that's a great point on the medicine adherence, that make sure that a lot of the misconception is you take the medicine and you get your numbers better, like you do cholesterol or hypertension, and you can come off of it. So thank you for sharing that. Dr. Rothschild, one to two resources that you have?
My best resource is my wife. I'm a big believer in cardiac rehab. It gets people out of the house, it gets them socialized, it gets them active. It's a good source where they can talk about their medications and things like that. I think the Heart Association has good material that can be brought as well. But then the better resource, they need a good therapeutic relationship with their medical caregivers. And it's not always a physician, it may be a nurse practitioner and all the expanders that we have. Again, some of the telemetry monitoring in terms of these management of chronic diseases, where we can get their weights and their blood pressures and their oxygen saturations, are really crucial as well as a resource that we need to make available to them. And then encouraging them to utilize their groups around them. It may be as simple as going to their church groups or other types of community things that can be very helpful, because you need to keep these people engaged and active.
Thank you, Dr. Rothschild. Totally agree that you need that social support network behind you, so that you really not only have your family support, but that also provider teams and community-based teams. A number of the organizations on the collaborative are networking and providing those services along with the local Department of Health. So thank you, for that, and to all of those in the audience that provide those services. And Wendy, if you could round out 1 to 2 things to close us out, that would be awesome.
I think I just want to hit back again on just like the education. I think the more education that you can give the patient, that's one of the best resources that you can give them. And just really making sure that they understand where and who to follow up with for their follow-up care, especially post-hospitalization. I think that's just a huge piece for them, and just to really tie up if they're taking all the right meds and getting everything that they need.
Thank you so much, Wendy. And really, again, Dr. Chen, Dr. Rothschild, and Wendy, thank you so much for talking to us today, at length about heart failure and preventing it and managing it, the tools and the resources that we can bring to our community. And of course, if we have family members, how we can support them as well. And I'm going to go ahead and turn it over now. If there are any questions you could add them in the chat for any of our panelists. Okay, I don't see anything in the chat, but if anything does come up after, please feel free to email us at the Healthy Hearts Collaborative email, and we will follow up with you. So I'll go ahead and turn it over to you, Tiffany. And again, thank you to our panelists. It was a great discussion.
Thanks, Juliet. And yes, thank you to our panel. Thank you to Jamie for being flexible and presenting early. Thanks to Juliet for organizing and facilitating this. Just shout out to, it truly takes a team to make this happen. So I'll go over updates really quick, or announcements, and then we'll get ready to close. For those I have not yet had the pleasure of meeting, my name is Tiffany Richards, and I lead the state's cardiovascular disease prevention program here. And this is just a little about me. I do want to make a plug for those who have joined today and are not yet a Healthy Hearts California member. I would encourage you to join. We will send out the link for new member registration. We also have a Healthy Hearts page you can check out. A few updates specific to the cardiovascular disease prevention program and Healthy Hearts. I did want to just share with the group that we are applying for our funding for 24-25. And part of that is shifting upstream to a more prevention-based focus. One example of how you're seeing this is our previous Healthy People 2030 objective related to increasing the control of high blood pressure in adults. And we're shifting that to improving cardiovascular health in adults, which we see will allow us to have a broader prevention-based brush for our efforts. I also just want to make a plug. We have an upcoming in-person event in June. And there's more information to come on that. If you are interested in being a presenter, that's being led by our Heartbeat California program. So please reach out to them. Third update pertains just to let everyone know that we are working on updating California's master plan for heart disease and stroke prevention and treatment. A lot of behind the scenes work, but the short story to a very long project is that we are anticipating releasing that in 2024, so more to come. And last but certainly not least, it is my pleasure to announce that Healthy Hearts California has a new co-chair. Nancy Song from American Heart Association is filling that role. So I'd like to encourage the group to welcome Nancy, and I will pass it to her to do her portion of announcements.
Hi, everybody. Hang on just a second. Trying to get on video for you. So my name is Nancy Song. I'm Senior Director of Community Impact here at the American Heart Association. I've got my life story up. I've got my master's in public health from the University of Arizona. I'm a native LA County, Long Beach, actually, to be specific. Went to Cal State LA to also receive my bachelor's in public health. I've done some work at the American Heart Association. Obviously, I've been here for like the last couple of years. Prior to my role at AHA, I used to work for the LA County Department of Public Health in various roles and serving in different capacities between 2015 to 2021. My very first job out of college was at Harbor UCLA, where I was a program assistant in the infection control department. Fun fact about me, I'm also a certified HIV prevention counselor. So, thank you for having me. I'm really excited about this opportunity to co-chair in this collaborative, and I'm looking forward to working with all of you a little bit more as we move forward in our work.
Thank you, Nancy, and welcome aboard.
Thank you.
So I think now we're going to ask Hattie, I'm going to go ahead and have you screen share if that's okay. I'm going to go ahead and do that so you could review the data with us. Okay, Hattie, you should be hopefully able to screen share. Hattie, are you able to share?
Let's see. Are you able to hear me?
Yes, we can now. Thank you.
Okay, so I'm just getting my system set here. I'll share in just a second. Here we go. Something important to all of us. It will not allow me to start video, but hopefully it will. Didn't share the right one. Stop share. I'll try again. Let's see.
We saw it a second ago, Hattie, just a minute ago.
There it is.
Yes.
Okay, this is the format we want to see it in. And what I want to draw our attention to, this is the state's Office of Patient Advocate, which shows the level of performance for various heart metrics by health plan. You can also look at this according to medical groups, specifically by county. But I wanted to just draw attention to the fact that we've made some good progress, especially with those health systems that are very integrated. Sharp Health Plan, very integrated with their medical group, same with Kaiser Health Plan and the medical group being able to control the care a bit. Same with Western Health Advantage, which is in the Sacramento region. But then you see these large health plans in the mid 60s and even some down into the 50s for just controlling blood pressure only to a modest measure of 140/90. And then this data is a bit out of date. It's 2021, but we've been working on this problem with the health plans for 15 plus years. So it's a little disappointing to see that the large network health plans are not doing better, even though they're actually making a lot of efforts, especially Blue Shield of California. They're actually starting a new blood pressure control program to try to work with specific medical groups that contract with them that have low scores. So I just wanted to call out that the data, unfortunately, is very delayed in being shared with us. So this is 2021, and when you bring to the attention of a health plan, say Blue Shield, that they're at 62% in good control, they've been doing a lot of work in the last 2 years. So this feels, really out of date when you're trying to work on quality improvement. So I'd love the Heart Association and the Department of Public Health to help get us more timely, critical data like this. Thank you for letting me share that.
Thank you, Hattie. And we definitely will be looking to work together to see how we can work with healthcare organizations and patients and providers to increase blood pressure control rates in patient populations.
What a great team today. Thanks for all your hard work in putting us together. I learned so much.
Thank you. Thank you, Hattie, for sharing as well. Are there any other shareholder updates that you would like to announce? Anybody on the team? If not, please add them in the chat or email us after and we'll include them in the post meeting recording.
I'd love to have everyone join us on Monday, November 13th from 12 to 2 when we're going to be dealing with the issue of increased risk among the South Asian population and how to reduce that. You can find more information on RightCare at berkeley.edu. Thanks.
Thank you. And Hattie, if you could drop that in the chat as well, that would be great. And so we're at time. So again, I wanted to thank all of our presenters today. Tiffany Richards, my co-chair. And if there's any other things that we can answer, please feel free again to email us directly or to drop it in the chat. As we close out the program today, you will get a brief survey that will pop up automatically. If you could just take it, it's 4 questions, just to help us make sure that we're covering content and providing quality programming for all of you in the audience. So thank you again for everybody so much for joining, and we hope you have a great day.
Hey, thank you all. Be well. Stay safe.
Yes.
It's been a pleasure.
Thank you.